Thank you so much for joining us. And more importantly, thank you so much for Dr. Frias for uh, giving some of his time and knowledge to present the central role of weight management in the care of people with type 2 diabetes. And as you know, obesity has become an epidemic around the world, especially in the United States. And Juan is an extremely well-known scientist who has conducted and published in the New England, the top journals on obesity, and he's a trialist. He's, he has conducted, I don't know how many hundreds of clinical trials. He's the medical director and principal investigator for Los Angeles Institute of Metabolic Research, and is a clinical professor of medicine at the University of Medicine Science in Los Angeles, California. We're for a big treat. So, Juan, thank you so much for giving us this lecture.
Okay, well, thank you. Make sure I'm not muted here. Yeah, thank you, Guillermo and Wendy, and for everyone for joining. So as Guillermo mentioned, I'm going to speak about the central role and the importance of weight management, particularly in type 2 diabetes. And we've really come such a long way from a pharmacotherapy perspective over the years. I mean, when I started, came out of residency and first started doing diabetes, we literally had sulfonylureas and insulin, and that was it. We had agents that actually increased weight and promoted hypoglycemia. And now we have 10, 11 classes of drugs, including the incretin or GLP-1 based medicine. And it's really changed how we manage diabetes and how we manage obesity. And you'll see that one of the key focuses that I will focus on is metabolic liver disease, because I think it's a disorder that often goes under-recognized. It's very easy to screen for, particularly to identify those patients who have so-called at-risk fibrosis and are at the highest risk of progressing to cirrhosis and a major liver outcome. So I think it's something that's clinically very important, as an interest of mine as well. So we'll get going here. Here are my disclosures. And I'll start just with this sort of prediction of where we're going to be in the US in 2030 with respect to obesity. And it's estimated that we'll go from somewhere around 40% today of the adult population being overweight and obese to almost 50%. And I think importantly, it's estimated that by 2030, 1/4 of the US population will actually have severe obesity, so class 2 or class 3 obesity with a BMI of greater than or equal to 35 kilograms per meter squared. So a tremendous increase, not only in the US, but globally. And this really is driving, or is an important driver of the increase in the prevalence of type 2 diabetes. And you can see that in the blue line here, the projections for the increase, and this is globally now, but the trend looks very similar in the US, of type 2 diabetes. And it's estimated that by 2050, there will be 1.3 billion people globally. In the US right now, we have the estimates are around 35 to 40 million people with diabetes. The majority of that is type 2 diabetes. About 25% of that is not diagnosed yet. So it's very important to be screening for this. And the projection is that this will increase to somewhere around 50 million during this time frame. So again, this is driven by obesity and also change in demographics, or an older population. And all of these cardiorenal metabolic diseases are very interlinked or interconnected, and really the root cause being insulin resistance, which it goes with obesity. And we have obesity, chronic kidney disease, type 2 diabetes, heart failure, and very importantly, metabolic liver disease as well. So all very interconnected. And the point that I'll try to make during the talk is that we really should be, in people with type 2 diabetes, managing overweight and obesity early to prevent, or at least help mitigate, some of these complications of obesity. If we turn now to the treatment algorithm, or the key points of the management of type 2 diabetes, really the central or overarching goals of care are to prevent complications and optimize quality of life, And this includes medications for glycemic management, but very importantly, also for weight management, traditional cardiovascular risk factor improvements of blood pressure, lipids as well, and then cardiorenal protection. So particularly now with the GLP-1 based medicines and also the SGLT2 inhibitors, very important not only to modify traditional cardiovascular risk factors, but use these medications with proven cardiovascular benefits in our patients when they're not contraindicated. And this comes straight from the American Diabetes Association standards of care this year in 2026. And this is sort of it's class A evidence that in people with type 2 diabetes and overweight and obesity, which represent about 90% of people with type 2 diabetes, weight management should represent a primary goal of treatment along with glycemic management. And in fact, this is a really nice paper by Ildi Lingve, which talks about the importance of treating obesity early to prevent not only the metabolic complications of obesity, but also the biomechanical complications, osteoarthritis, obstructive sleep apnea, and the psychological. So we should intervene upstream to address the key driver of many metabolic, biomechanical, and psychological disorders or complications of obesity by managing obesity and overweight as early as possible. And we know from many studies over the year that the greater the weight loss, generally the greater the metabolic benefit. And you can see here with increase in weight reduction, once you get into the 10 or 15% weight reduction, you're talking about improvements in cardiovascular disease and chronic kidney disease, again, obstructive sleep apnea. And as you get into the range where we're seeing now with GLP-1 based medicines more often, type 2 diabetes remission and cardiovascular mortality improving as well. And as I mentioned, I want to focus on metabolic liver disease, or so-called MASLD and MASH. And so this is an increase of fat in the liver greater than 5% and excluding other causes of steatosis. But generally in people with obesity and type 2 diabetes, many of which have metabolic liver disease or steatosis or increased steatosis, this is due in the vast majority of cases due to MASLD. And it is very common. Globally, it's estimated that about a third of the adult population has MASLD. In the United States, the estimates are around 40% of adults. And this is much more common in people with type 2 diabetes. So the prevalence of MASLD, so metabolic liver disease, is about twofold higher in people with diabetes. And not only is the steatosis or the percent of patients with sort of simple steatosis, if you will, more common, about 56% of the global population. But in people with type 2 diabetes, it's a much more aggressive disease. So the progression from MASLD to MASH, now we're talking about steatohepatitis, so inflammation, hepatocyte damage, the potential for fibrosis progressing to F4 or stage 4 fibrosis, which is cirrhosis, is much more common. And it's estimated that somewhere between 15, maybe 20% of people with type 2 diabetes already have advanced fibrosis. So they have what we term at-risk MASH, so stage 2, stage 3 fibrosis, where stage 4 again is cirrhosis. And these are patients that are much higher risk of progressing to cirrhosis and many negative outcomes of cirrhosis and liver disease. So let me go to a case. This is a patient I saw a few years ago. He was a 64-year-old gentleman, 14-year history of type 2 diabetes. He really had no complaint. He came to the clinic for management of diabetes, and he's got a history of obesity, dyslipidemia, no known atherosclerotic cardiovascular disease, but definitely a very high risk. And he had an abdominal ultrasound for other reasons about 3 months prior to coming in, and had the typical sort of incidental finding we have of increased echogenicity consistent with fatty liver. There you see a social history. Importantly, he does not drink alcohol. And sometimes you get these issues can confound, particularly in people who drink a lot of alcohol. They can have sort of a mixed picture, if you will. of metabolic and alcoholic liver disease. Here we see his medication, so maximal tolerated or maximal effective dose of metformin. He's on insulin glargine, 40 units every evening, on atorvastatin, 40 milligrams. Blood pressure looks reasonably good. He is obese with a BMI of 34 and very poor glycemic control. A1C is 8.8%. So if we look at guidelines, and this is just one example, but anywhere you read, and we know this from the data, is that in people with metabolic liver disease, fibrosis is the most important prognostic factor, and it's correlated with liver-related outcomes and mortality. And the presence of advanced fibrosis identifies patients in need of in-depth hepatologic investigation, including on a case-by-case basis, confirmatory biopsy, and intensive therapies. And this is actually a really nice paper by Ken Cusi in Gainesville, Florida, that was published last year and also is prominent in the ADA guidelines this year. And it's a diagnostic algorithm for risk stratification for the prevention of cirrhosis in patients with MASLD. And it's a very simple test that we can do to help stratify patients that in general can be managed by the primary care physician or the endocrinologist or a non-hepatologist, and which patients we should be more concerned about and refer to the liver specialist. In our case, we often enter them into clinical trials. But again, people with type 2 diabetes, with prediabetes, with obesity and greater than one other cardiovascular risk factor, the test they should have is called a FIB-4. And this is included now in many electronic medical record systems. And the FIB-4, and we'll talk about it a bit more, it's simple. It consists of an ALT and AST, so the aminotransferases, platelets, and age. And it's a formula that usually you use an app to calculate or is calculated for you. And the magic number, if you will, in general is greater than or equal to 1.3. If it is not greater than or equal to 1.3, this is a very sensitive test. There's a very low likelihood that the patient is going to have at-risk MASH, so basically more advanced fibrosis. And in general, these are patients who can be managed in primary care. And the FIB-4 can be repeated depending on the score and other factors and whether the patient has, increases a lot in body weight, et cetera, every 1 to 2 years. If the FIB-4, though, is greater than 1.3, you can see some of the numbers there and don't need to memorize this by any means. Certainly, if it's greater than 2.67, that might be a patient that just gets referred straight to the hepatologist. This is an indicator that more than likely, and it's not a terribly specific test, but more than likely this patient has more advanced fibrosis. But the order of test here that you see is this LSM there at the top. I don't have it highlighted, but this is a liver stiffness measure. So this is transient elastography or a fiber scan. Not everyone has access to these, but this basically you can check with a fiber scan, which is sort of quote unquote ultrasound-like. If it is over 8 kilopascals, then that patient should be referred to the liver specialist. If it's less, this again is a patient that possibly could be managed by primary care. And then there's mention too of the enhanced liver fibrosis test, or ELF, which is a non-invasive blood test, which also is a predictor of fibrosis. So the bottom line, what we're trying to do here is in primary care anyways, to risk stratify patients. Screen everyone. Everyone with type 2 diabetes should have a FIB-4. If the FIB-4 is really high, they can go either to transient elastography, have this ELF test done, or just get sent to the liver specialist for further evaluation. This is a very similar algorithm. In fact, it's based on the American Association for the Study of Liver Disease, the AASLD. Again, with the goal of knowing who can be managed by primary care, you see here based on the FIB-4 index, and who, if you go down this algorithm of higher FIB-4 or FIB-4 that's intermediate with a high liver stiffness measure, referring to the hepatologist. And this is just one example of the many apps that are out there, but this is an app that calculates the FIB4 and actually is very nice from the American Gastroenterological Association and goes through not only the calculation of who should be screened, I should say, but also calculating the FIB4 and then going a little bit deeper and giving some advice here. So again, this is based on age. If you look on the far right, the aminotransferases, so ALT, AST, and platelets. So let's go back to our patient now who had significant steatosis on an ultrasound, terrible glycemic control, and is obese. So we look at his labs now. Renal function looks reasonable. He doesn't have albuminuria. You see his LDL cholesterol is good. We may want to increase his statin. And ALT and AST are high, but within the normal range. And I would say I would not get thrown off by that. Many of these patients, and certainly most of my patients who end up having significant steatosis and MASH and even fibrosis, oftentimes have high normal ALT and AST, and most of the time are asymptomatic as well. You also see the patient's albumin there and kind of a low-ish platelet count. So if we plug this into the FIB4, these are our numbers, and we get a 2.5 basically. So this falls in that intermediate category. It's certainly higher than 1.3, and it is definitely worrisome. We happen to have fiber scans. We did a fiber scan on this patient. The cap, which is shown there, which is 400, that's called the controlled attenuation parameter. The max that it reads is 400. We already know this patient has a lot of fat in the liver based on the ultrasound. But here we see the liver stiffness measure, which is 9.6, so over 8. This, along with the FIB4, indicates that this patient, if they went for biopsy, likely would have F2 or F3 fibrosis. So, and we'll come back to this patient in a bit. So what are the overarching goals of the treatment of metabolic liver disease? One is to prevent liver-related morbidity and mortality. So really, we're talking about progression to cirrhosis, esophageal varices, and encephalopathy, liver transplant, and ultimately death. But also, these patients have even higher risk of cardiovascular morbidity and mortality than patients with type 2 diabetes who do not have metabolic liver disease. And this is just a reminder slide that we do need to really manage in these patients, not only their glucose and their body weight, but also their traditional risk factors, blood pressure, lipids, tobacco cessation, if appropriate, antiplatelet therapy. And this also comes from the ADA guidelines and Ken Cusi's paper and really walks through a treatment algorithm. Again, anyone with MASLD, healthy lifestyle, weight loss if indicated, in most of these patients it is indicated, optimal diabetes management. These patients are oftentimes more difficult to manage because they have a lot of hepatic insulin resistance. As we mentioned, cardiovascular risk reduction, even more aggressive than we are potentially with type 2 or as aggressive. And then some patients may need to go for metabolic surgery, particularly type 2 diabetes, BMI over 30, if they can't tolerate GLP-1 based medicines. But if we find this at-risk MASH based on the FIB4, the either the ELF test or FibroScan, really we have two options that are approved now. So resmetirom, which is a thyroid hormone receptor beta agonist, it's been approved for F2 and F3 fibrosis, or for non-invasive tests that would indicate F2 or F3, and also GLP-1 receptor agonists. And the only one that's approved at this point specifically for MASH with fibrosis is semaglutide. So trade name would be Ozempic or Wegovy, actually, at 2.4 milligrams once weekly. But as I'll show, many others have been studied. So the GLP-1 based medicines become very important, and we have a ton of evidence over the years. I mean, I was fortunate to be at Amylin Pharmaceuticals in 2005 when we launched both pramlintide, the amylin analog, and the first GLP-1 receptor agonist, which was twice daily exenatide. But we've come a long way with these medications. So not only in treatment of glucose, in treatment of overweight and obesity, but also to prevent so many other complications of obesity and of insulin resistance. So improvement in cardiovascular risk, in heart failure with preserved ejection fraction, in chronic kidney disease, decrease in cardiovascular death and stroke. So a lot of evidence. And basically the thoughts are that these agents act on inflammation at the end of the day, and this may be causing some of the improvements that we see there in macrovascular disease and also in liver and kidney disease, with direct effects by GLP-1 receptor activation on T cells, but also improvement in inflammation through the reduction in body weight. And if we look at guidelines again, with respect to the management of people with type 2 diabetes, from a pharmacotherapeutic perspective, I mean, clearly diabetes self-management, education, diet, physical activity, very important. But the GLP-1 based therapies, not only in people with high risk or pre-existing cardiovascular disease, where they should be considered independent of the A1C and independent of other medications they're on, such as metformin, and are often used, and it's a great combination with SGLT2 inhibitors, but also really across the span of people with type 2 diabetes. They are very high with respect to efficacy for weight management, particularly tirzepatide and semaglutide, and also very high efficacy with respect to glucose management, particularly high-dose dulaglutide, but semaglutide and tirzepatide as well. And as I mentioned, very important to at least consider in the treatment of MASLD, particularly semaglutide, which is now approved, and sometimes in combination also with either low doses, generally what I would use, pioglitazone, which is known to have some positive hepatic effects as well. So I want to take a little time now and just go through some physiology and how over the years we've really harnessed the incretin and glucagon physiology in development of these agents. So if we look at GLP-1 agonism, so GLP-1 receptor agonism at the level of the central nervous system, they act on receptors that are extremely important in appetite regulation, satiety. So the reduction in appetite, increase in satiety, so a reduction in energy or food intake. They have the so-called incretin effect. So they augment nutrient-stimulated insulin secretion at the level of the beta cell. At the level of the alpha cell, they reduce glucagon secretion and they modulate gastric emptying as well. So examples of these would be semaglutide or dulaglutide, trade name Ozempic, and Trulicity. If we now add GIP agonism, you have central effects as well. So the reduction in appetite. I don't think this energy expenditure is increased. This is the second incretin hormone. In fact, normally it has more effect on the beta cell than GLP-1. So you get this augmentation of insulin secretion. But very importantly, there really are no GLP-1 receptors on adipocytes. But GIP receptors are highly expressed on adipocytes and improve adipocyte insulin sensitivity, and they improve the so-called buffering capacity of the adipose tissue. So the appropriate uptake of triglycerides in the postprandial state when someone eats, and then the appropriate release of free fatty acids in the post-absorptive state. And what this is thought to do, and it's been shown in preclinical studies, and maybe part of why you get sort of better control, if you will, with GIP, GLP-1 dual agonism, is that by having more sort of normal, if you will, adipose tissue, you prevent ectopic accumulation of fat. And this could be in multiple tissues, including the liver. So the example of this is tirzepatide, and there are others in clinical development. Now, if we add glucagon, again, we're getting a reduction in appetite. Here, possibly increase energy expenditure. So not only a reduction in energy or food intake, but a ramping up of energy expenditure as well. You get delayed gastric empty. Now, with glucagon agonism, you do get an increase in gluconeogenesis, so in the production of glucose by the liver and glycogenolysis, or the breakdown of glycogen. But this generally, as you'll see when you combine these agents with a GLP-1 agonist or GIP agonism, the increase in insulin sort of overcomes that, if you will. But very importantly, you do get an increase in fatty acid oxidation. Now, there are no or virtually no GLP-1 and GIP receptors in the liver. So the effect we see on the liver of GLP-1 monoagonists, for example, really are secondary effects, so through the weight reduction, et cetera. But glucagon receptors are highly expressed in the liver, and you get an increase in fatty acid oxidation. And these agents are very potent with respect to metabolic liver disease. And there are in development GLP-1 glucagon receptor agonists. So these are unimolecular multi-agonists of GLP-1 and glucagon. I'm not going to speak about those, but they're in development for weight management as well as treatment of MASH. And then I will speak about retatrutide, which is a triple agonist of the GIP, GLP-1, and glucagon receptor, which is in the late stages now of clinical development. So starting with semaglutide, dulaglutide, and I'm just going to talk about semaglutide here and focus on metabolic liver disease. So this is a relatively recently published study called the ESSENCE trial. It was a phase 3 trial looking at semaglutide for 72 weeks, and it's got a very long-term extension as well, but initially for 72 weeks in people with MASH, with stage 2 or stage 3 biopsy-proven fibrosis. So there you see histological evidence of fibrosis stage 2 or 3. And the trial objectives, you see, it was a placebo-controlled study, 2.4 milligrams once weekly of semaglutide. It was escalated as per the label versus placebo. In part 1, you see there's 72 weeks. It's currently in part 2, which is event-driven and looking at major liver outcomes. But the first part of the study looks specifically at liver histology. And all of these studies look at, you can see there in part 1, steatohepatitis reduction without worsening of fibrosis, and improvement in fibrosis without worsening of steatohepatitis. And this is what's shown here with semaglutide in orange and placebo in blue after the 72 weeks of management. And this is looking at the percentage of patients who had on the left resolution of steatohepatitis and no worsening of liver fibrosis, significantly greater with semaglutide versus placebo. And then the second primary endpoint, the reduction in liver fibrosis without worsening of steatohepatitis, also significantly better for semaglutide versus placebo. In this study, patients lost, I'm recalling correctly, about 10 to 11% of their body weight during the 72 weeks of the study. And you can see here that there were not only improvement in liver histology, but also improvement in blood pressure, in hemoglobin A1C, particularly in those patients with type 2 diabetes at baseline, in high sensitivity CRP, so improvements in inflammation as well, and in lipids. And as with the GLP-1 class, the most common side effects were GI in nature. You can see the incidence there of nausea, for example, about 36% with semaglutide versus 13% with placebo. But most of this is mild in severity. Most of it did not, the vast majority did not result in discontinuation of the drug. And in fact, if you see adverse events leading to trial discontinuation, 2.6% with semaglutide and 3.3% with placebo. So basically similar. And based on this study, semaglutide was approved in August of last year for the treatment of so-called at-risk MASH, so patients with MASH and moderate to advanced fibrosis. Let me move on now to tirzepatide. So this is is a dual agonist of GIP and the GLP-1 receptor. It's a so-called unimolecular multi-agonist. So it's one molecule. In fact, it's based on the peptide sequence of GIP, and it's been modified to bind to and activate both GIP and GLP-1 receptors. It has a 20 carbon fatty acid moiety that's attached to it. This binds to albumin, extending the half-life, so half-life of about 5 days. So as you probably know, and this tirzepatide is Mounjaro or Zepbound for obesity. Those are the trade names. It's administered once weekly. So it's a single molecule with activity at two pharmacologic targets, and it was approved for type 2 diabetes based on the SURPASS studies, for overweight and obesity based on the SURMOUNT trials. And this is one of the SURPASS trials. This was a trial that looked at patients on metformin with or without an SGLT2 inhibitor and compared and looked at tirzepatide versus placebo. And you can see here, this is an MRI protein density fat fraction. So MRI PDFF, this is commonly done in all of these liver clinical trials. And you can see a baseline on the left. The percent fat in this liver is 27%. Now, again, abnormal is over 5. Some people would say even over 3%. So this is a patient with 27% of the liver is fat. You can see at the bottom there, the BMI is 45. The patient weighs 134 kilos, terrible glycemic control, 9.3 a baseline. This was a 52-week study. And in fact, it didn't compare to placebo. I misspoke. It compared to insulin glargine, so tirzepatide versus insulin glargine. But you see, anyway, at 52 weeks, in this patient who was on 5 milligrams of tirzepatide, we looked at 5, 10, and 15 milligram dose, there was a reduction in liver fat to normal, 2.5%. And you can see there was a 20% reduction in body weight, and the A1C went from 9.3 to 6.1%. So a little anecdotal, but this was published in Lancet Diabetes and Endocrinology. Now, there was a specific study, and this was a phase 2 study called Synergy NASH, looking at tirzepatide in people with F2 and F3 fibrosis. And this was a 52-week study. And the bottom line, what was seen was quite sort of similar directionally than what was seen with semaglutide in the Essence trial, but resolution of MASH with no worsening of fibrosis in 62% of patients at the highest tirzepatide dose versus 10% of placebo-treated patients. And then a decrease of over one or more fibrosis stages without worsening of MASH or the steatohepatitis in 51% of patients treated with tirzepatide versus 30% of patients treated with placebo. So this is being looked at further in later phase studies at this point. I'll take a quick sort of a break, if you will, from the efficacy. And I think it's very important. And I think most of us, have used these agents and know the gastrointestinal side effects are the most common side effects. Generally nausea, vomiting, diarrhea, constipation. And these are usually in the clinical trials and certainly in my practice experience, mild to moderate. They can be mitigated certainly by slow dose escalation, but also by dietary measures and making sure patients aren't eating a lot of fatty foods, which slow gastric emptying, that they're stopping eating when they feel satiated and don't overeat. Sometimes we do need medications to treat, but generally they can be mitigated. And some patients just don't tolerate, but it's a very small percentage. The other side effect that I wanted to point out is sarcopenia that, particularly as we're getting into agents now like retatrutide, which is not approved yet, where you're getting mean reductions in body weight of almost 30%. And 60% of patients losing greater than 25% of their body weight. We need to be careful, particularly in very at-risk patients, elderly patients, that they do not lose a lot of muscle mass. Now, no matter how you lose weight, you're going to lose some lean mass. I mean, without a doubt, these agents, the majority of the weight loss is fat mass, and the ratio of lean to fat improves significantly. But in general, you're seeing with these agents a loss in lean mass, which is not all muscle. I mean, it's anything that's not fat, basically, of around 20, maybe 25%. And these patients, this could be adaptive. These patients are weighing much less and may not need all that muscle. But again, we need to be careful. I stress high protein diet. The patients see the dietitian, usually what they call protein first. So starting with protein in the meal and making sure they're doing some resistance training to try to mitigate it. They're always going to lose some lean mass, but to lose as little as possible. And then just being very careful again with at-risk patients. Let me turn to retatrutide now. I'm going to do a quick time check. And this is a triagonist again of GIP, GLP-1, and glucagon. As with tirzepatide, it's this unimolecular multi-agonist, so unimolecular, one molecule that's been modified. It's based on the backbone of GIP. It's 39 amino acids, C20, 20 carbon fatty acid moiety that binds to albumin, extends the half-life. So this now is a single molecule with activity at three targets: GIP, GLP-1, and glucagon. I was fortunate to be involved in these clinical trials. In phase 2, we studied patients with type 2 diabetes, with obesity, without diabetes. And then this sub-analysis of this New England paper in obesity without diabetes of patients who had MRI PDFF, so a measure of liver fat over 10% at baseline, and seeing how did those patients do with respect to liver fat. It was not a biopsy, though. And these are the high level results in people with type 2 diabetes. This is at 36 weeks. You see an improvement in A1C from 8.3 by 2% to a mean of about 6.3. And the body weight had not yet plateaued at 36 weeks. Generally, with these agents, on average, anyway, and everyone's different, you plateau at about 52 weeks or a little beyond that, but really a very steep trajectory here. And that's the total kilos that I've circled there, but it ends up being over 15% weight reduction in people with type 2 diabetes. And this is very high for type 2 diabetes, certainly at 36 weeks. In people without diabetes who generally lose more weight, this was a study out to 48 weeks with retatrutide versus placebo. And you can see a 25% average reduction in body weight. Again, it looks like it has not plateaued at this point, and about half of the patients losing greater than 25% or a quarter of their body weight. So very, very potent agent. And this is the sub-trial that I mentioned that was published in Nature, which looked at liver fat content in people who had a baseline liver fat over 10%. And the bottom line is you want to see at least a 30% reduction, a relative reduction in liver fat. This has been associated with improvements in disease progression and in prognosis. And here, actually, the mean reduction was over 80%. 100% of patients had over 30% reduction. The mean reduction was around 80%, and over 90% of these patients who had a mean of 20% liver fat content, you see that on the left there, over 90% went to less than 5%, and this is only at 48 weeks before weight has stabilized in these patients. So this could be a very important agent for metabolic liver disease. I'm going to speed it up a little bit here, and there are programs that are ongoing and should be finishing relatively soon. The Transcend program in type 2 diabetes, the Triumph program in obesity, and one study which I think is very interesting, we're not part of this, is tirzepatide versus retatrutide in people with obesity. This was just top line results, not a publication. We have not seen all the data, but the first of the Triumph study. So this is retatrutide with the primary endpoint of obesity. And what was shown in this trial was that I believe it's 72 weeks, but in any case, at the 12 milligram dose, almost a 30% reduction in body weight, so 28.7%. And these were all patients with knee osteoarthritis, significantly improved osteoarthritis symptoms as well. And about 60% of these patients lost over 25% of their body weight. So let me come back to our patient now. So 64-year-old Latino male, very poor glycemic control. He's obese. You see his medications there, metformin, insulin glargine for diabetes. And indeterminate risk based on the FIB-4 and the liver stiffness measure was over 8. So kind of concerning here. He was treated with lifestyle modification. He did initiate GLP-1 based therapy, and it was titrated to the maximal dose, and also an SGLT2 inhibitor. And in these patients, usually we can reduce their insulin quite a bit. In fact, if I recall correctly, this patient stopped the insulin glargine as we were escalating the GLP-1 based therapy. And that's something that's important to do to avoid hypoglycemia. No, he didn't stop, reduced dose. I have it right there in the bullet. And these were his final results. So the A1C came down almost 2% points to 6.9. He lost about 20% of his body weight. You can see his lipids looked a little bit better. The LDL was already pretty good. Reduction in aminotransferases, improvement in the platelet count. So we recalculate the FIB-4. Now he's at 1.25. So he's certainly below the 1.3. And since I have easy access to the fiber scan, this was November 2020. And when we repeated in February of 2022, you see his values here, significant reduction in this CAP or controlled attenuation parameter, so reduction in liver fat, but also more importantly, an improvement in fibrosis based on the liver stiffness measure with the fiber scan, so from 9.6 to 5.0, which is quite normal. I'm going to look at the time here, Guillermo. Let me go through this really quick. I just want to talk about one additional combination that I think is super interesting, which is cagrilintide. So amylin, as you probably know, and we have the drug pramlintide or Similan that's been approved since 2005. Amylin is a second beta cell hormone that is co-secreted from the pancreas with insulin. It's got a lot of effects, but it binds centrally to reduce appetite. It slows or modulates gastric emptying. It reduces glucagon concentrations or secretion as well. And cagrilintide, as you remember, pramlintide is very short acting, 3 times a day, is a long acting amylin analog. It's got about 85% homology to the native amylin hormone, half-life about 7 days. And it's being studied in combination. Now, this is not a single molecule, a unimolecular agonist. This is a combination. So it's a fixed dose combination of cagrilintide with semaglutide. And in phase 2, we published this last year, 2 years ago. Geez, time flies. This was a phase 2 study in people with type 2 diabetes. So this was cagrisema or cagrilintide with semaglutide versus semaglutide 2.4 milligrams versus cagrilintide alone. And here we see the reduction or the change in hemoglobin A1C, not statistically different than semaglutide, but numerically better, 2.2%. So very, very good efficacy there. And even more impressive with respect to body weight. And again, you don't plateau at 32 weeks, but about a 16% reduction in type 2 diabetes versus you can see semaglutide sort of underperformed in this study, 5.1%, but cagrilintide alone, 8.1%. And I will say that it is cagrilintide on its own being studied for overweight and obesity. And there are many other once weekly and even more than once weekly amylin analogs that are in clinical development as well. I'm going to skip that, but basically there's a clinical development program for diabetes and obesity. And this is the obesity study in people with type 2 diabetes. This is a phase 3 study published in the New England Journal last year. Bottom line here is weight loss, very consistent with the phase 2 study, about 16% on average at 68 weeks. With about slightly over half of the patients having greater than 15% weight loss. This is quite consistent with tirzepatide. Very nice A1C reduction in these people with type 2 diabetes, about a 2% reduction with slightly over 80% achieving an A1C of less than or equal to 6.5%. Improvements in cardiometabolic risk factors, so blood pressure, CRP, lipids as well, waist circumference. And as with the selective GLP-1 receptor agonists and the dual and triple agonists, GI side effects most common. Again, with cagrisema, you have semaglutide and an amylin analog. And you can see here over the 68 weeks, just showing the incidence over time of nausea in this case, quite a similar pattern, but lower for vomiting and diarrhea. But most of it occurred early in the course of therapy and dissipates over time. So obesity is a critical upstream driver of type 2 diabetes and its complications and should be treated early as a core element of diabetes care. Greater sustained weight loss yields progressive multi-organ benefits, including improvements in glycemia, cardiometabolic risk, and metabolic liver disease. MASLD, MASH are highly prevalent in type 2 diabetes. We should screen everybody. And fibrosis is the strongest predictor of prognosis, requiring early identification and risk stratification. Do this early. Better to start treating the patient before they reach, significant fibrosis. And start with a very simple test, the FIB4. GLP-1 based therapies provide broad disease-modifying effects addressing body weight, glycemia, cardiorenal, and metabolic liver disease simultaneously. So we're really addressing a lot of issues with one class of drugs. We need to use them safely and in the right patients, but very potent drugs. And emerging multi-agonist and combination therapies, so retatrutide, other combinations like CagriSema, expand future potential, enabling earlier and more effective intervention across the metabolic disease spectrum. And I would say with these emerging incretin-based and multi-agonist therapies, we really are entering an era where obesity treatment can change the trajectory of type 2 diabetes, cardiorenal disease, and metabolic liver disease. So with that, I'd like to thank you. This is the beautiful building, the Disney Concert Hall in downtown Los Angeles. And our clinic this is on kind of the north part of Grand Avenue in downtown. And our new clinic is located at California Hospital Medical Center, which was one of the Dignity Health hospitals, also on Grand Avenue and South Grand Avenue, not too far from this. So with that, I'd like to thank you for your attention. Sorry, I went over a bit, and I think we have some time for questions.
Yeah, thank you. Well, this is fantastic. At least we do have some treatment that is going to improve quality of life in patients with obesity and type 2 diabetes. And they've been sending me several questions. So one of the questions is about half of the patients in real world studies discontinue these medicines after a year or two. What do you do with these patients? How do you manage them?
Yeah,
You can
that's first of all, it's a really good point. And I think we all know from clinical experience and we know from specific clinical trials like STEP 4 and SURMOUNT 4 that when you stop these drugs, weight goes back up in general. So it's very hard to maintain that weight reduction, not being on the drugs. And this is a chronic disease that requires chronic therapy. What we do with those patients, it really depends on why they stopped. I mean, sometimes it's because of terrible side effects. If that's the case, sometimes switching them to an alternative agent works. I don't know why some people can't tolerate semaglutide, but can tirzepatide, and vice versa, don't tolerate tirzepatide, but can semaglutide. Sometimes that's it, or going for a lower dose. But I think, oftentimes it's financial issues, insurance issues. That's tough to sort of get around. So I think it's really getting to the core of why they have stopped. Maybe they just are fatigued, disinterested, try to get them remotivated and just, address sort of the root cause of why they stopped the drug.
Yeah. And another question here from my group says that sarcopenia is reported in 10 to 50% of patients in the older adults. And if you get patients over age of 60, somewhere around 10 to 25 has sarcopenia, functional. How do you assess? I mean, would that mean that you should be careful in studying these agents in the older adults? How do you assess sarcopenia? When do you think that it is safe to use that?
Yeah, no, so I think they are safe to use in the majority of these patients. I would just say being extra careful. Now, I don't, I think going slower, not necessarily advancing the dose to the maximal dose. I think, as I mentioned before, integrating good dietary practices and some at least resistance training. I mean, all of that is helpful. I think you can visually assess these patients. There are other things that can be done that are much more objective, grip strength, for example. I mean, at the end of the day, it's really is muscle function worsening or not. But whoever asked that is absolutely right. And you even look at the semaglutide label, it will say that there was an increase in hip fracture, for example. You don't know if this is because patients got very sarcopenic and then just were not as stable, perhaps, or they just lost so much weight they didn't have the cushion if they fell, if you will. But it's an important concern, and I would say my approach is just go slower, maybe lower targets of weight reduction, and instituting proper diet and physical activity, which would be resistance training, or at least some resistance exercise. But we really have to individualize.
There is oh, Dr. Idris has a question, I believe.
Yeah, thank you. It's on the
Oh,
same.
by the way, keep sending me all your questions, okay? All right.
It's on the same line for Dr. Frias. Thank you so much for the presentation. What do you think about these molecules being developed that they're promising to block the muscle wasting when using these drugs? I mean, every time you go to EDA, you're seeing so many companies trying to develop such molecules. Thank you.
Yeah, so I think you know what the early data looks like it's promising that it definitely mitigates the loss of muscle. So these are like bimagrumab, these are monoclonal antibodies that are antagonists of like the activin type 2 receptor, and they sort of the myosin activin pathway, if you will, sort of puts the brakes on muscle development. So if you inhibit that, theoretically, then you're going to get more promotion of muscle. So I think that's important to look at, and maybe for the right patient. I don't get for the right patient, and it would be that more at-risk patient of sarcopenia. I think these could be extremely important. I think we need to wait and see what the data show. But I think, the one thing to take into account, and I know it's not your question, is that no matter how you lose weight, whether it's diet only, whether it's metabolic surgery, whether it's with these GLP-1 based medicines, I mean, you're always going to get some lean mass loss, and not all of lean mass is muscle necessarily. But I think what's very important is you don't want to get quote unquote sarcopenia, and you do, irrespective of how you lose it with these agents, you lose much more fat than you lose lean mass. And again, this ratio of fat to lean is improved significantly, as are all of these other risk factors. So I do think it's important, but the importance is just the amount of fat that they're losing as well.
So this crazy government that we have right now in the United States, I heard in NPR and CNN that the rate of obesity in this country has significantly reduced. Is that a politic statement, or is it true? Because you showed that it's going to go all the way up.
I don't know. You know what? I've heard that too, but I haven't seen the actual data behind that. I think it's, at the end of the day, it's probably how you define obesity. So really, Guillermo, I'm not sure. I don't know if it's sort of more propaganda than truth, but I would say certainly in my clinical experience, and when I just go out in the street and look around, I don't see things decreasing too much. And it's still too high, even if it has decreased. I mean, we don't need 40% of the population with a BMI over 30.
Yeah, and I have a very nice question here related to cost. There, is a significant barrier for utilization of these GLP-1s and companies. Now that the field is becoming crowded with more of these agents coming up, what do you think is going to be the cost, and how are you going to choose one to the other?
Yeah, I don't know the answer to that question, but certainly some of these have started to go, and more will start going generic. So I think we'll have options that are generic, that are slightly less expensive. I would imagine that with increased competition, generally cost will go down, but really not my area of expertise. How you select one versus the other, that's a tough question, sort of independent of insurance, if you will. If you want to go just fully evidence-based for MASH with fibrosis and you want to use a GLP-1, you would go with semaglutide. But certainly, oftentimes in these patients, I mean, you're managing your primary goal may be reduction in body weight. And then you see that, well, tirzepatide actually on average is more potent than semaglutide. So I think you just have to consider what is the primary goal that you're using the agent for. And we've seen in the SURPASS studies and the SURMOUNT studies, which are the tirzepatide clinical development program, it's definitely more potent on average than semaglutide. But semaglutide has a lot of data too now for kidney disease with the FLOW study, for hepatic disease with the ESSENCE trial. So I think we need to individualize and you know what? They're all pretty good if used in the right patient and used safely. And I just like to go a little bit slower in practice, quite frankly.
And
That's just me.
one of my fellows here just sent me a little note. It says that in addition to do a liver biopsy, why we should send this patient with liver disease, obesity, or early liver disease and obesity to the specialist? They're going to treat the patient with weight loss medication. Can we do it ourselves?
Yeah, you certainly can do it yourself. I would think the general recommendation is, first of all, most primary care physicians don't necessarily either check for this or do it themselves. So I would say if you're an endocrinologist, for example, or just a
Yeah,
clinician in general is very interested in liver disease, there's no need to send them. But I would say when they're getting more advanced, I mean, I generally would like a hepatologist to look at them to confirm. I mean, there could be something else going on causing the steatosis, and this is what they do to rule out anything else that could be going on. Generally, they don't even do the biopsy. And if they do a biopsy, it's generally to sort of clarify maybe just some inconsistencies in the picture, if you will. So they have more experience with resmetirom as well. We probably have more experience with GLP-1 based therapy. So it's not a must. And these are general recommendations. Also, when the patients start getting into the cirrhotic, I mean, you're kind of getting them into care there, then they need to do surveillance for hepatocellular carcinoma, for esophageal varices. So when you get to F4, it really becomes, I think, management that should be done by a hepatologist.
And the last question, I promise you, because I don't know the answer. It says that in one of the slides, early slides that you presented, it appears that the MASH is higher in Europe than in the United States, and for sure higher in Latin America. Any comments about that?
Yeah, I think it's probably dietary. I didn't, honestly, I don't see why it would be higher in Europe, quite frankly. But Hispanics definitely have a higher risk, and there is a lot of MASH in Latin America, and I would say also in the Middle East, very high prevalence in India as well. So some of that is genetic. And if you look at Africa, it's quite low. So Black people are protected from advancement of steatosis to MASH and fibrosis. And those are genetic reasons. So some of it is genetic, some of it is dietary.
Well, with that, I don't have any more questions for you, but this is unbelievable lecture, and I think that it just showed the prevalence of obesity, the interaction of multiple comorbidities, and I think that these agents are more than just obesity treatment. They're weight management in the way that it's not just the heart, the weight, but it's the heart, the kidneys, the joints, as you said. So, Juan, thank you so much for joining us today, and great lecture.